Super, thanks. So as you'll see from the cover slide, this presentation is actually from both François-Pierre and I. He'll be in charge of the chat box. So if you have any questions or comments that he can deal with immediately during the webinar, please don't hesitate to ask them. And if there are points of clarification where you'd prefer an immediate response, and it would be helpful to have that response before we get to the Q&A period, you can also flag that for François-Pierre, and he'll interrupt me. So I think our presentation will probably be in the 20 to 25 minute range, then we'll turn it over to Robyn, and then we'll open it up for questions and answers. So I'm just going to start off with some acknowledgments, and in the process of that, just give you a feel for the methods that underpinned today's presentation. So first, we built on an Ontario-focused rapid synthesis that we did at the request of the Government of Ontario that helped us to do some work to Canadianize the definition and characteristics of a rapid learning system and develop an approach to map the assets and gaps in that province. But then in response to a request from CIHR's IHSPR, which Robyn heads, and the Canadian Health Services and Policy Research Alliance, we then extended that work to include the federal, national, pan-Canadian level, all 10 provincial health systems, and the 3 territorial health systems, and they funded this work. The work itself was produced with what some people would call a co-production model, so we were guided at key steps in the process by both a working group and then a smaller steering committee. The steering committee was drawn from the working group, co-chaired by Tom Noseworthy and Denis Roy, and benefited significantly from the input as well of CHSPR's Executive Director, Diane Finegood. We then, when we were collecting data for this, we did it in 2 ways. I'm actually going to deal with the last bullet point first. First, we constructed jurisdiction-specific tables based on both website and document reviews, and then we conducted key informant interviews. So if you go to the second to last bullet, you'll see that we ended up conducting 50 key informants. In some provinces and territories, as many as 6 people. And in a very small number of provinces, we were only able to secure 1 or 2 key informants despite many efforts to follow up. We sent the resulting tables to many individuals. We call them the table checkers, and we also revised the report based on the input from 1 policymaker, 1 stakeholder, and 1 researcher. The work was divided up across 6 of us at the McMaster Health Forum, myself and François-Pierre Gauvin, as well as 4 of my colleagues, Christina, Kale, and Carrie, and Mike, each of us taking responsibility for 2 to 3 jurisdictions. And we also involved a collaborator with highly relevant Canadian and U.S. experience, Rob Reed. So that's a bit of our approach. Next, I'm going to turn to the top 10 lessons. And if you quickly go down through this list, you'll see I'm going to talk about the definition we've proposed, what we learned from the research literature, a feel for some of the assets we identified, a feel for some of the gaps also that we identified. And you'll see the one that is highlighted is our conclusion that what really matters is how well these assets are connected to enable rapid learning and improvement. Then we'll move on to areas where people have focused their rapid learning health systems thinking in the recent past, but also where they're planning to do that in future. We'll talk about some windows of opportunity that can be capitalized on in moving in this direction. We'll also talk about where it might make sense to be thinking about pan-Canadian collaboration. So, of course, most of the work in this space will have to happen within individual provincial and territorial health systems, but there are times where we can work very constructively across jurisdictions. And then we'll conclude with some thoughts about why this framework we think has such potential to get us farther, faster together, and also some very pragmatic considerations about how we talk about this in different jurisdictions and the types of people we engage and how they might also differ by the context. So that's a feel for the lessons. I think I have 7 slides that are specific to a characteristic, and for 3 of the characteristics, I have 2 slides. So if I move on to lesson 1. So lesson 1 has to do with the definition, where we concluded that the definition needs to start with patients and cover both all levels of the system, And by levels, we mean self-management or self-care, the professional encounter, the program, the organization, the district or region or zone, and the government. And it also needs to cover all parts of the system. So in jurisdictions that have regions or zones, it has to cover all of those. All the sectors, which we typically think of as moving from home and community care through primary care to specialty, including acute care, rehabilitation, long-term care, and public health. It has to cover all conditions, so sometimes rapid learning health system thinking is very far advanced in areas like cancer or cardiac care or trauma care, but in other categories of conditions, it might be much less well established. We also need to be using a rapid learning systems lens when we think about treatments or categories of treatments like prescription drugs, and also for populations, particularly vulnerable populations. And as you'll see in a minute, the one that we focused on here were the elderly. So we need a health and a research system that at all levels and in all parts is, and now I'll come to the 7 characteristics that we think comprise a rapid learning health system. So the first characteristic is it needs to be anchored on patient needs, perspectives, and aspirations. The next 2 characteristics are that it needs to be driven by timely data and by timely evidence. The 4th and the 5th characteristics are that it needs to be supported by appropriate decision supports and aligned governance, financial, and delivery arrangements. And the last 2 are it needs to be enabled with a culture of and competencies for rapid learning and improvement. And a couple of caveats or elaborations on these points. By patients, we mean both actual and potential patients, families and caregivers, and citizens that may not have interacted directly with the health system. I think one of the most notable findings from our key informant interviews is how diverse individuals really see themselves in these characteristics. They might find themselves feeling more closely tied to 1 or 2 of them, but they can often see themselves in ways that isn't necessarily the case with other frameworks that are sometimes used in health systems. The other point is that a remarkable number of people really see significant value in better connecting and filling gaps in these assets to accelerate the creation of rapid learning health systems across Canada. So in my 20-odd years post-PhD of working in the health system space, I have not seen a framework before like this that has gotten such traction as a motivating tool for a variety of different people to work collaboratively. So that's the definition. One elaboration on this when we speak about the different levels is that when the Institute of Medicine in the United States first started to talk about what they called rapid learning healthcare systems, they were more focused at the clinical encounter program and organization level. And they talked about the iterative nature of rapid learning and improvement, moving from problem definition to designing care, to implementing a plan, to evaluating, to making adjustments, and then to disseminating the results to improve care across the system. Folks like myself who are more focused on the policy level, the government level, see direct analogs here in terms of how governments and health authorities clarify problems and causes, select options, identify implementation considerations, and monitor implementation and evaluate impact. And then if we move to the patient level, there are also analogs here with patients seeking to understand their risk factors and conditions, make choices, overcome obstacles to behavior change, monitor their condition, and so on. So the rapid learning health systems thinking, while originally designed primarily for that middle column, also has a great deal of relevance when we move to the higher government level and when we start to think about patients. Second lesson learned is that the research literature provides no recipe, but single studies point to key factors or strategies that can support the creation of a rapid learning health system and have done so in particular contexts. So one of the examples here would be the importance of engaging frontline clinicians. And we see that happening in a much more comprehensive way in Alberta with their strategic clinical networks than perhaps it happens in some other provinces. Two other observations about the research literature. One is there's much less attention given to some characteristics, and we've offered two here: engaged patients and aligned governance, financial, and delivery arrangements compared to others. So the ones that tend to get more attention are the data side, digital capture, linkage, and timely sharing, and the timely production of research evidence. And we see a fair degree of attention to what I highlighted at the beginning was our most important lesson, how assets are connected in particular contexts. The other observation about the research literature, which you'll find laid out in an appendix to the report, are there many ethical issues that need to be addressed in rapid learning systems. For example, there's a lot of confusion about which learning and improvement efforts require what types of ethical oversight. One of the interesting things we found across Canada is some provinces are very far along in being able to stream research to the appropriate level of ethical oversight, whereas others have not fully worked that through yet. Lesson 3 is that documenting assets and to a lesser extent gaps isn't rocket science, but it needs specificity and regular updating. So in about a 2.5-month period, we were able to document a remarkable array of assets across 14 jurisdictions. The first jurisdiction is a hard one to describe. It includes the federal, national, and pan-Canadian levels. So we have some initiatives in Canada where they are a reflection of formal federal government accountability, such as for Indigenous peoples, military and veterans, and prisoners. But more often we see initiatives that are national or pan-Canadian in nature. And then we have the 10 provinces and 3 territories, each of which have their own health system. So we produced 3 tables for every jurisdiction, and we'll provide you with the link a little bit later in the webinar to all of this material. So there are 14 appendices, so 1 per jurisdiction, with each appendix including a table for assets and gaps at the level of the entire health system, at the level of primary care as one of 6 sectors, and for the elderly as one of many populations. So in addition to the jurisdiction-specific appendices that you'll be able to download, we also have ones that cut across jurisdictions with a whole health system lens, with a primary care lens, and with an older adults lens. In each table, we use both the health and the research system as separate columns to try and keep a helpful distinction. And the rows were the 7 characteristics of a rapid learning system. But what we learned from the Ontario work that preceded this was the importance of having prompts for the types of things we were looking for with each of the characteristics. So if you want a quick sense of more detail behind each of the characteristics, those prompts, which appear in every table, would be helpful. Now, of course, having looked at the health system as a whole and zeroed in on one sector and one population, we're missing other sectors and populations where there are no doubt other rich experiences. We're also missing a regional or zone level lens. We're missing a lens through different conditions like cancer, and we're missing a lens through different categories of treatments or health determinants. So at the end of the day, a provincial or territorial rapid learning system probably doesn't exist. We have multiple interconnected rapid learning health systems that are focusing at the level of different sectors, populations, conditions, treatments, and regions. The prompts and the assets, of course, need regular updating in future. So that's lesson 3. Lesson 4 was the list of assets is remarkably rich, even in small jurisdictions, but there are some common gaps. So I think all of us who worked on this report were struck by how much is going on, whether or not those activities have been formally identified as supporting rapid learning health systems. They exist and can easily be put to that end. The four gaps that I'm going to focus on are come from the first two of the characteristics and the last two. So the first one, patients are often not meaningfully engaged in what dials to move, and by that we mean in terms of the care experiences and outcomes that are priorities for rapid learning and improvement. And often they don't have mechanisms beyond complaints and voting to register their frustration when the dials don't move. Second area, which is aligned with that second characteristic about rapid learning systems, is that data about patient experiences are often not linked and shared in a timely way. Many jurisdictions are focused on developing a jurisdiction-wide electronic health record that will in the near term often not include key sectors like primary care, and many of them are also very focused on producing one-off or annual data reports rather than many small, immediately actionable reports. So lots of fantastic activities in both the patient engagement and the data space. These are two examples of some areas of emphasis that we perceived as some common gaps. The other two gaps that we'll highlight here are that the culture of rapid learning and improvement is not yet widespread across levels and across areas of focus, particularly the rapid part of that. And competencies in data analytics and implementation science are often not sufficiently well distributed within and across the system to support rapid learning and improvement, both across levels and across areas of focus. So remarkable array of assets, but still some common gaps, often with particular areas of emphasis within a characteristic. And again, I've focused on four of them here. The big message, and this was the one that was highlighted in the list of 10, is that we at least have come to the conclusion that what really matters is how well these assets are connected to enable rapid learning and improvement. And to try and illustrate this, we picked 5 examples, 4 where we thought people had done really interesting work in trying to join up the assets, and those were primary care in Newfoundland and Labrador, for the elderly in Alberta, to address the opioid crisis in Quebec, and to try and drive improvements in a particular region outside Toronto in Ontario. And we also picked one where we thought there was tremendous potential for joining up that was latent, but that could be captured if the recommendation coming out from the national level ends up being that we need to move towards the implementation of a national pharmacare plan. We found many assets that exist that are not as effectively joined up as they could be. The one example we're going to give you here is for the elderly population in Alberta. So here what we're trying to show are connections among assets that support rapid learning and improvement for the elderly. So we identified 2 groups that took particular action to connect assets, and then I'll talk about how those assets are then arrayed by the 7 rapid learning health system characteristics. And there's a bit of a time dimension to this figure, with earlier or more upstream actions preceding later or more downstream actions. So if I move to the first part of this figure, this one starts off showing the final 3 characteristics, and you'll see that there's an oval associated with the 5th and the 7th characteristic. So with aligned governance, financial, and delivery arrangements, we have Alberta Health Services Provincial Seniors Health Program, which shares a medical leader with a strategic clinical network on seniors health, which I'll come to in a minute. And it has direct connections to both Alberta Health, the government, and the 5 zones in Alberta to enable rapid learning and improvement. The other group that we identified as being key here was the Strategic Clinical Network on Seniors Health that has the competencies to scale up effective practices in clinical care. So this is the earlier or more upstream groups that took action. Now, if we move to the top of the list of characteristics, these are the first 3. So both of those organizations work with groups of patient and family members to guide their rapid learning and improvement efforts. They've also engaged patients and families in a priority setting exercise for research about the elderly using a James Lind Alliance approach. Both groups also analyze local, provincial, and national data to identify clinical problems and monitor the implementation of improvement efforts. And both of them work with Alberta Health Services knowledge management staff to synthesize data and evidence about clinical problems and options for improvement. Now, if I come lower down within this figure, you've already seen the oval to the left about the provincial program, but now if I move around the rest of that circle, the program and the network provide care pathways and other decision supports. And I give a particular example where they've gotten traction in the area of medical assistance in dying. So that's within the appropriate decision supports row. The program works with Alberta Health to align governance, financial, and delivery arrangements to support rapid learning and improvement. And the program and, to some extent, the network also work with the 5 zones to align delivery arrangements to support rapid learning and improvement. And finally, both organizations, the provincial program and the Strategic Clinical Network, benefit from Alberta Health Services investments in a supportive culture in areas like team-based care. So the overall figure, it's hard to read now, but you'll see going down in the first column the 7 characteristics of a rapid learning system. You'll see in the second column those 2 ovals that I began with, the groups that took action, the provincial program and the strategic clinical networks, and then a variety of connections they made among assets in order to drive improvements in care. So that's a particular example of the effective joining up of assets in a system to drive learning and improvement. I'll move on now to Lesson 6. Lesson 6 is that there have been some areas that have been or will be the focus of sustained efforts. So we spoke to, as I mentioned before, 50 people across Canada. Not surprisingly, a number of them highlighted home and community care and mental health and addictions as examples of current and future areas of focus. That almost certainly is tied in part to the federal dollars that are supporting innovation in that area, but in many provinces and territories, the focus on those 2 areas long preceded the federal government investments. People also focused on Indigenous peoples, but of course it's up to Indigenous leaders to decide whether and how to use aspects of a rapid learning systems framework in their own work. And another example of where people are currently using this perspective and will be doing even more in future is surgery. Now, of course, there are many other examples, but these are some of the ones that came up more often. If I now move on to Lesson 7, Lesson 7 is about the need to capitalize on windows of opportunity when they open. So the first one, which I've highlighted in blue, is the growing use of the framework and concepts related to rapid learning systems. And I've given 3 provinces. I could have given more, but BC, Ontario, New Brunswick were the 3 that we gave the example of here. And there are also supporting bodies advancing this approach, including the Canadian Health Services and Policy Research Alliance, and we'll also hear from Robyn about IHSPR's work, which is now, I think, 4 years into really pushing this across the country, which has been fantastic. Another example of a window of opportunity, the reconfiguring of pan-Canadian health organizations. That offers tremendous opportunity for better aligning whatever comes out of that process in service to driving rapid learning and improvement across provincial and territorial health systems. Third window arises because we have a new CIHR president and a strategic planning process, and we have the prospect of a SPOR strategy on patient-oriented research renewal. That also offers opportunities. We see the growing roles of patient and family advisors. So whether or not leaders in the system push for this, they will increasingly face patient and family advisors that are demanding more rapid learning and improvement. A growing capacity for responsive and timely health systems research. Canada has for years had a remarkably rich group of health systems researchers, but more and more focus on being responsive and timely. Some people identified the amalgamation of regional health authorities like Saskatchewan and Northwest Territories. Other provinces like Alberta re-centralized a while back, but they see the potential for this as accelerating this movement as well. Some of our interviewees identified new governing parties as also creating windows of opportunity. But the flip side of that is that in provinces that have been getting traction with this approach, elections of a new governing party can also disrupt the movement towards a rapid learning health system. So elections can, of course, cut both ways. And finally, the proposal being developed for the implementation of national pharmacare also offers a potential way in here. Lesson 8 is about interdependencies and issue-based commonalities that can serve as focal points for pan-Canadian collaboration. So as I said at the beginning, provincial and territorial health systems will be where the real heavy lifting happens, but there are many potential arguments for pan-Canadian collaboration in this space. We asked about both interdependencies and issue-based commonalities. In the former, we've given two examples here, the planned SPOR National Data Platform that's just been announced that Kim McGrail and colleagues will be leading out of BC, but with the involvement of people from across Canada, that will permit benchmarking, the evaluation of natural experiments, and so on. So very rigorous cross-provincial and territorial analyses. And another example in areas where we have shared specialty care arrangements across jurisdictions, either because of highly specialized care needs or for those living in small jurisdictions or near borders. Some examples of where many, if not all, provinces and territories are struggling with similar issues are care for mental health and addictions, including the opioid crisis, and care in rural and remote communities. So particular supports for rapid learning and improvement in those areas may make sense. One other example of an issue-based commonality that was particularly intriguing, it only came up from one interviewee, but it struck us as very relevant, the need to develop accreditation standards and other supports for rapid learning organizations and systems. So we know whether we're moving in the right direction and what more we can do. Lesson 9, I alluded to this before, that this framework to me provides a way in for all players that are invested in the success of our health systems across Canada. And we think that this framework offers the potential to get us farther, faster together. It can enable data and evidence-informed transformations at all levels and in all parts of the system in ways that are more rapid, better sustained locally, more widely spread. It can motivate greater collaboration among and enable greater impacts of all elements of the research system. And finally, it can better leverage any quality improvement and other infrastructure operating at the interface between the health and the research system. So again, I think we can get farther, faster together. Just on the research system side alone, if you look down the left column of this table, you'll see the variety of different people that, in my view, bring an excellent and helpful research-based perspective to the table, and they can support rapid learning and improvement. They each have unique comparative advantages. Data analytics, particularly helpful at clarifying problems and monitoring implementation. Down at the bottom, evaluation, very good at evaluating impact. Whatever the issue that comes up, we need all of these people bringing their comparative advantages so we understand problems and their causes. We've thought through options, we've thought through implementation, we've thought through monitoring and evaluation, and we iteratively improve as we go. The blue highlighted row is where we sit at the McMaster Health Forum, but over the years we've increasingly come to realize that we can bring a lot to the table, but we bring even better work to the table when we're able to collaborate across these different groups. Lesson 10, the last one, what you call it, and by it I mean a rapid learning health system, and who you engage will vary by context. This piece isn't in the report. I give it to you as an illustration. On Friday, I was at a meeting with a number of colleagues talking about the Ontario context. At this particular moment in time, saying we want to create a rapid learning health system in Ontario is not going to be the type of language that necessarily resonates with our elected officials. What we might say instead is we want to drive point-of-care improvements that matter to patients and that are based on the best available data and evidence. So that is a different way of talking about the same thing, but one that resonates with elected officials in a particular jurisdiction at a particular moment in time. And we have to adjust our wording in this way depending on our context. Another way that language can vary is what staff are called. So if you're in an Ontario hospital, you might think of engaging staff that work in business intelligence, clinical informatics, decision support, and the list goes on. If you're in a different jurisdiction, there might be different language. And one of the challenges, though, across jurisdictions is the fact that these staff might exist in the specialty and specifically the acute care sector, but they're often lacking in other domains like the primary care sector where there isn't this kind of distributed capacity. So we need to use the right language, engage the right people in the right context. So that brings me back to the 10 lessons. These have been 5. What really matters is how well the assets are connected to enable rapid learning and improvement. My final slide is next steps. So on the forum side, what we'll be doing is posting this webinar within a few days. So you'll be able to share the link with colleagues if you think it might be useful to them. We have already posted the report, and I don't know, Steve or FP, if you are able to post that, I'll see if I can do it myself so that you can pull up the actual report. Just need to change it to all attendees. Oh, there we go. Now you have it twice. So what you'll find there is the report. You'll find 14 jurisdiction-specific appendices. If you're sitting in Alberta, you can just click on the Alberta one. You'll also find 3 other appendices, one for the health system as a whole, where we combined all of those tables across jurisdictions, one primary care alone, and one focused only on the elderly population. We'll also be sharing the findings at an upcoming CASPR event, other events in BC, we hope Alberta and other jurisdictions. In Ontario, we're already planning an Ontario-specific stakeholder dialogue about how to take forward this work in this province, and we're now embedding the approach in a new 14-country collaborative called PEARLS, where we're working outside health, trying to support countries to achieve the Sustainable Development Goals, and we're using all of this learning in that work. At CHSPRA, the working group is going to use this report as a jumping off point. Unfortunately, Diane, Tom, Vinny were not able to join us today, but they are very keen to circle back to their working group and decide how they can move this forward. And you'll hear shortly from Robyn. Although she's coming to the end of her term, she probably has a sense about where things might be heading on this front. And I think it's in no small part because of Robyn's leadership. 4 years of this being front and center in IHSPR's strategic plan that we are in such a great space for moving forward on rapid learning health systems across Canada right now. So that's it for me. Steve, I'll turn it back to you.
Great, thanks, John. We'll turn it over to Robyn, I think, if she's able to share some of her insights from her time at CIHR, and then following Robyn, we'll move to our Q&A.
Great.
Okay, perfect. Okay, so first of all, thank you, John and François-Pierre, for just a yeoman's job at doing this and in such a short period of time. We are incredibly appreciative. This provides us with fabulous insight as to where we are now in Canada and where we need to go. So just a wonderful roadmap to start with. And I hear you in saying the linking up of the assets is pretty important, and also that this is just the beginning, and this will need to be something that we constantly are updating as we go along. So just to give you a bit of a perspective on where we are with both the Institute for Health Services and Policy Research, CIHR as a whole, and also the Canadian Health Services and Policy Research Alliance. So I'll just start with the Canadian Health Services and Policy Research Alliance. And this is an alliance of essentially funders, training programs, health services, and policy research centers across Canada who have come together and identified a number of common areas that they want to work on, support the development of a strategic direction on for Canada, and collaborate on funding important gaps that we need to address if we want to move things forward. So they've picked off two very important, well, three important areas, I should say, for this. The first was developing and building capacity, and this was highlighted by John in his, focus on where the gaps are and where the assets are, is that we realize that if we want to actually be able to use the data and actually embed rapid responsive research in the backbone of healthcare, is that we needed a different kind of person who would basically be embedded in these environments. And so there was this, the Canadian Health Services Policy Research Alliance did form a training modernization group, which has been highly successful at developing a vision and a strategy for creating first postdoctoral fellows and now doctoral students who are involved in and embedded in employment environments that are healthcare related, both delivery organizations, policy organizations, and advocacy organizations, to essentially embed research within the backbone of these organizations and take on the kind of challenges that would be necessary for the kind of rapid learning, evidence generation, and improvements in care. So hats off to them. They now have a cohort of over almost 100 fellows and doctoral students in over 55 partner organizations, and that's rapidly growing, and there'll be another round of these kind of fellowships in the coming year, where we have involvement from many of the provincial funders, almost all of the institutes at CIHR. So this has been a winning proposition for trying to populate Canada with really very talented people who are working hand in hand with delivery organizations to bring about the kind of rapid, responsive kind of research that is necessary as part and parcel of a learning health system. The second is a group that has kicked off, the Learning Health System Group, which John already mentioned. This is co-led by Denis Roy here from Quebec, who is the chief scientist at INES, which is a quality improvement organization of provincial level in Quebec, and Tom Noseworthy, who's been leading the strategic clinical networks in Alberta and has now moved over to lead the academic health network as a first of its kind in British Columbia learning health system. So these two individuals have a small working group, and the work that John and François-Pierre have done has been instrumental as kind of the starting point for where this group will take things next. So your comments will take note of them here, because I think that the group will very much want to hear your thoughts and reflections on where we see things moving forward. In terms of the additional levers that are present, as John mentioned, learning health systems has been a priority, a strategic priority for our institute for the last 4 years. And we have invested in a number of asset building activities, including the building more of a research base and innovation base within primary health care, which we see as fundamental to improving the way we deliver care in Canada. And second, in growing essentially the digital health space, so that we do have the ability not just to have kind of archaic ways of collecting data through paper records, but we have an increasing number, an array of data that's coming from remote monitoring, it's coming from personal health records, it's coming from electronic health records and clinical information systems, so that we do have not just the capacity to get this data and actually wrap it up, on an annual basis, but we have the capacity to start using this digital data with ideally even artificial intelligence attached to that, to move the ball forward and actually being able to create something that we ask a question on Monday and we learn the answer on Friday would be sort of where we see rapid going in this space. The second is very important, I think, a very important lever for promoting the learning health system in Canada, and that is the strategy for patient-oriented research, which was already mentioned by John, but just to let you know where this is what they call in the federal government a ringfence, meaning it's dedicated to the strategy for patient-oriented research, amount of money that is led by CIHR, but in partnership with the provinces and territories. So CIHR's contribution is $60 million a year to this initiative, and it's partnered one-to-one at least with the provinces and territories and with the other networks, which I'll mention just briefly. But its vision for the strategy for patient-oriented research is to improve the outcomes and patient experience for Canadians by the year 2025. And to do that, it invested in patient engagement in a fairly major way with and support units, which hosted many support services for learning health systems, one of which was patient engagement, the second of which was data platforms, which are desperately needed. If you want to learn on the go, you really have to have data. The third in capacity development, particularly in terms of patient co-designed research. So SPORE is fairly important to this, and also included in this is just the recent launch, as John mentioned, of the national data platform, which will allow us in Canada for the first time to mine the natural experiments that are happening in our 13 different healthcare systems, so that it really will deal with that at multiple levels, not just at a clinical level, but at a regional and provincial level as well, in terms of differences in policy for addressing common challenges that each health system has in Canada. The second component of SPORE, and SPORE has been in it 5 years, gradually staggered in building support units across the country, investing in initially a primary health care data network, a mental health network for youth and mental health, and 5 chronic disease networks. But there's now a renewal of SPORE to look at where should we be investing to meet this vision of improved outcomes and experience by 2025. So a SPORE 2.0, as we'd call it, is being formulated with deep engagement with the provinces, the territories, the existing networks and assets we already have to help us define where to move to next. And I think that we can imagine that we'll see definitely the investment in capacity development, which has been a little bit delinquent in the SPORE initiative, both in embedding clinician scientists within the health system, but also people who can lead implementation and transformation and care, which isn't necessarily at all a scientist, but involves clinical and policy leadership. So you can see that being supported through essentially the next version or next phase of SPORE, and also an increasing number of networks, rather than big networks, but networks that are fit for purpose to specific challenges that are confronted at the provincial and territorial level, but also a desire to network these networks together when they're on common topics such as aging or mental health and addictions, so that we begin to learn, as we've done in primary care by networking provincial and territorial networks together, learn from the kind of cross-jurisdictional research and implementation and policy transformation that we can do there. So I think we'll see that coming. So the national data platform for sure is going to be a huge asset for us. An increasing number of nimble networks that are going to be substantively based, and now a renewed and important strategic investment in capacity development beyond the fellowship and doctoral student level, but in the leadership level for both clinical science and policy science. And last but not least, John alluded to the fact that there are ethical challenges, I think, here. There's always been a kind of a gray zone between what we call typically quality improvement or program evaluation and research, and that has muddied the waters and has for some time. And so our institute put forward to both the Standing Committee of Ethics of Governing Council of CIHR as well as the Tri-Council Secretariat the challenges that are confronted by those who aspire to create rapid learning health systems. So a working committee will be struck that brings together these two very important groups to provide us with a set of principles on how to address that and examples that are already beginning to emerge across the country. So I think we can look forward to some concrete action on that front, providing some leadership for ethics committees across the country so that we're not recreating the wheel and creating unnecessary barriers to ourselves. And with that, I think I'll wind up and once again thank John and François-Pierre for their incredible work and look forward to any questions.
Great, thanks so much, Robyn. I know FP's been furiously typing and answering some questions already as we've gone, but we'll maybe try and get through a few more here before our time is up, and then if people have any additional questions after the fact, please feel free to email us at forum@mcmaster.ca and we'll do our best to address them. So one question I know that it came in was that health systems focus on the big measures that are publicly reported, such as inpatient or acute care. How important is it to inform rapid learning to also adopt standardized measures of community-delivered care? Now, FP just wrote and said the report touches on home and community care and the importance of capturing, synthesizing, linking, and sharing data, but perhaps, John, do you want to just expand on that quickly?
Yep, absolutely. So, as I mentioned before, our view is we need rapid learning and improvement happening across sectors, and that definitely includes home and community care. And on the data side, then to match, we absolutely need the data from there as well. So I think we've often, been looking under the light post where we have the robust data, but we increasingly need that data from the variety of settings where people are actually receiving that care, and we need to make sure that it's focused both on patient experiences and patient outcomes. So I think absolutely. Some other quick responses to the ones that I got through in the chat box. Co-design. I'm sure there's a great academic definition. I just think of it from more of a layperson, that patients and families are either equally or meaningfully, depending on which adverb you prefer, involved in designing, and then there's a long list of nouns after that: services, programs, and so on. So that's how we interpreted and used the term in the report. The question about, from Esther, I think it was about integrated health research system. I'm not sure if that has a particular connotation for people. I would have, if I can jump back up to my slide with 7 groups, I would interpret an integrated, Steve, I had already got back to it. It was 8 maybe. It's down a few, or I can jump in. Down, it's a table. I would have, just based on the phrase, this one 9, I would have said an integrated research system is one where these people are working collaboratively and playing to their comparative advantages. I think what we're talking about with the rapid learning health system is where people that are involved at all levels on the health system side, operational people, strategy people, government people, people working right at the front line, all of them are working together to try and improve patient experiences and outcomes with the support of people on the research system side. But if your definition of integrated health research system includes all of those key players on the health system side, the ones that actually drive the improvements in healthcare, then okay, we could call it that. But I'm worried about something that only mentions research system and doesn't acknowledge that 90% of the action, 95% of the action is of course happening happening on the health system side. Some other quick examples. I think it was Ryan that asked how I think the question was, how did we engage patients in the process? So in every jurisdiction, we tried to interview at least one patient or family member among what we were striving for 5 in each jurisdiction. So we wanted to make sure at least one of the 5 in every jurisdiction was a patient or family member. And of course, we also touched on the research literature about patient engagement, and we wove in what we know of that research literature into the report. But by putting patients as the absolute first one, pointing out that they're the ones that need to say what the dials need to be set at and which ones need to be focused on, for me, they're absolutely front and center. Could we have done an even better job of engaging them in the report? Absolutely. But we did try in every jurisdiction to make sure at least one of the voices out of our optimal number of 5 was a patient and family member. Mark asked about how this can apply in the health promotion and disease prevention sector. We think just as robustly. In fact, we're taking it with our new PEARLS initiative way beyond health into housing, education, social services, the environment, an array of different areas with that new initiative, Partners in Evidence-Driven Rapid Learning in Social Systems. So our view is it applies equally well when you move beyond health care into a broad variety of areas. And then I think it was Julia that asked, were we considering patients and citizens the same? No, but what we did was at the beginning I had a slide that said, in our definition, and often through the presentation, when I say patients, I have a very fulsome sense of that. So it means patients and families and caregivers, and also citizens, people that don't currently interact with the health system, but they're taxpayers and voters. And some engagement mechanisms are more focused only on those with direct lived experience, patients, or direct lived experience as caregivers. Other engagement mechanisms might be more focused on the general public and not focused on their lived experiences with healthcare, and others might be a mix between them too. So in the interest of brevity, we picked a single term, patients, to mean that wide variety of individuals, but we think that engagement mechanisms will look different depending on who it is that you're engaging. So those are some quick answers to the ones I saw in the chat box.
That's great. Thanks. Robyn, did you have anything to add to those?
No, thank you very much, John, for that kind of comprehensive response. Oh, maybe just one thing, and that is that the National Data Platform, as part of the requirements, is to integrate essentially population level, which has been funded through Canada Health Infoway, lab, diagnostic imaging, and prescription drug information at the provincial territorial level into the local platforms and then into the national data platform, as well as electronic medical record data. So I think the issue of don't have data from that space and timeliness of data is something that we aspire to actually close that gap as rapidly as possible through this investment. And that investment is about $80 million.
Thanks, Robyn. And I know both you and John.
Oh, yes. I was just going to say, sorry, I was just glancing down. In answer to Mark's question, yes, about whether we could talk about population level outcomes, not just patient outcomes, absolutely. And that's where this whole challenge comes to that I tried to get at with my last point. We need to find the right language for the right audience. So much of the audience for this are people involved in direct service provision. And so patient outcomes works and it keeps them focused on what matters. But if you're focused on population-based interventions, then absolutely population-based population health outcomes is the way to go. So it's one of those unfortunate things. In any presentation, you have to play to the majority, but you're absolutely right. If you're in the promotion prevention space, we need better language, and that can easily be substituted. Sorry about that, Steve.
Oh, that's okay, thanks. I was just going to say, I know that both you and Robyn have touched quickly on a few points about, where this could go in the future, and I think there's a good question here that kind of wraps up our discussion today, that just somebody was asking if somebody wanted to do a deeper, more exhaustive dive into a particular province's assets or gaps to expand on this work, where would you start and what methodology would you use to expand on this work?
Yeah, so my quick reaction would be fantastic because, you know, as a bunch of outsiders, despite how much time and effort we put into the website and document reviews and the key informant interviews and all the checks and balances we put in, anybody who's nested within a particular health system is going to have an even richer understanding of what's there. So I think the more people that are spoken to, the better. So if we had much more time, we would have done many, many more key informant interviews because there's only so much that you can do from the website and document reviews. So these documents are now sitting on the report. We would be delighted if people take them as a jumping off point for more in-depth work. And if you do plan to do that, I would just say two things. One is email us and we'll send you a Word document so you don't have to repopulate the table from scratch. And second, keep Robyn and Diane at IHSPR and CHSPR up to speed. I guess Rick Laser, once he takes over from Robyn, so that they know what's happening and they can build on your work. But this has to be, at the end of the day, picked up by people in individual health systems. And if you want to run with it from a perspective of that, great. If you're a cancer person and you want to do this for cancer, great. If you're in another sector, home and community care, and you want to do it for home and community care, fantastic. We need as much of this out there as we can so people build on what's already out there.
Great, thanks. We have one more just quick question if we can just take 30 seconds. So Gary was asking if vice presidents of research at universities are being engaged in discussions and planning to adjust the culture and incentives in academia to support engaged scholarship in a bigger way than it's currently done.
Robyn, probably. I hope they are. We were not doing it. In the course of this work, we've come across some hospital research institutes like Trillium Health Partners and others that have really embraced this and kind of reconceptualized what a hospital research institute is meant to do. So I would hope VPs of research are taking this seriously. But Robyn, are you aware of particular activities in this area?
Yes, there are a couple of activities. One is to actually, we are in the midst of an ongoing experiment with changing the way we fund research through the Innovative Clinical Trials Program, where we're using a rewarding success model so that you're rewarded for successful implementation, successful partnership in transforming and improving healthcare in the form of a grant payback for the kind of value that you produce. So that really changes the paradigm. So it's no longer based on papers and presentations at conferences, but really on success on the ground. And I think that caters to a different kind of entrepreneurial, innovative researcher than our typical metrics, and yet it allows research funding to roll back into organizations that have these kind of individuals in their roster. The second area is basically the new president is, as John mentioned, is rolling out a strategic planning initiative and very much wants to see capacity development for the array of scientific domains as part and parcel of that, and the university VPs and UD delegates essentially deeply engaged in this process that really is a partnership between funding agencies and the universities and their counterparts, and so this will be very much part of this president's mandate. And the third area has just slipped my mind suddenly. Sorry about that, jet lag.
That's quite all right. Well, I'd just like to, I think, wrap it up. We're out of time, so just wanted to thank John and Robyn and FP as well for joining us today and doing such a great presentation and answering a lot of questions. If people do have more, and I'm not sure we got through the full list, but please email us at forum@mcmaster.ca and we'll try and do our best to get through to them. We will also be posting a recording from today's webinar on our website probably sometime later this week. So please go back and check that out or forward it on to any colleagues that you think might be interested. So thanks again, and look forward to having you join us for some of our future webinars as well.
Thanks, everybody. Bye-bye.
Thank you.